welcome to episode 4 of the Sickle Cell Society Podcast, supported by NHS England. Now, today we're collaborating with the UK Thalassaemia Society. We're going to be talking about genotypes, testing, and answering some of your questions. So why don't we get started?
My name is Gabriel Theophanous. I'm a beta thalassaemia major patient, and I'm also the operations manager at the UK Thalassaemia Society.
My name is Iyamide Thomas. I'm the Sickle Cell Society's NHS engagement lead, working on the project we do with the screening program.
I'm Amanda Hogan. I work for NHS England in the antenatal and newborn screening teams, and I am the Sickle Cell and Thalassaemia screening program manager, as well as the newborn pathway implementation lead.
Hello, I'm Kechi Anyanwu. I'm community matron for South East London Sickle Cell and Thalassaemia services covering Guy's, King's, Lewisham and Queen Elizabeth, and are also the chairperson for STAMAP, which is Sickle Cell and Thalassaemia Association for Nurses, Midwife and Allied Professionals. Thank you.
I'm Oddie Cooper. I'm a parent of a thalassaemia patient, and I'm also the Vice Chair of the UK Thalassaemia Society.
My name is Fumi Foster. I live with sickle cell. I'm also the father of a child who is a carrier as well. I work as a school administrator, but I also do some work with the society with Yamide every now and again.
That's great. Thank you so much. Now, to our experts on the panel, I'd love to ask, how would you describe what thalassaemia is to someone who might not know?
Sure. So in very simple terms, people with thalassaemia don't make their own blood. So every 2 to 4 weeks, we have to have blood transfusions. And basically, blood transfusions keep us alive. When you're having such regular transfusions, you're overloading your body with iron. So we have to have chelation therapy to remove the iron from our body. So this is just very simple terms of what thalassaemia is and how we live with it day to day.
Editor's note to clarify. People with thalassaemia do produce blood, but do not make enough haemoglobin and healthy red blood cells, which can mean regular blood transfusions are needed.
Thank you. And Iyamide, you've got some lovely props on your lap. Tell me about sickle cell.
Okay, sickle cell is a collective term that describes a series of related conditions which affect your hemoglobin in your blood. It's inherited. If you have sickle cell, rather than your round blood cells remaining round when hemoglobin, your blood is going around, your body giving up its oxygen, the blood cells change from this round shape to a sickle shape. Sickle is a farmer's tool, like a cutlass. And these sickle cells start getting stuck within your body, and that causes severe pain known as a crisis. It can cause organ damage over time, and also the sickle cells don't last as long as these ones, so it causes anemia as well.
Thank you for sharing that with me, both of you. Really good, clear explanations there. So on both the Sickle Cell Society website and the UK Thalassaemia site, a big kind of inquiry people have is about screening and testing. So I want to talk a bit about that. Why is it important to screen and test for sickle cell and thalassaemia?
Both conditions are inherited. So for thalassaemia, if the father and the mother are both thalassaemia trait, then there's a 1 in 4 chance that every pregnancy your child will have thalassaemia major. So we obviously promote the screening so that people can know their carrier status. I think this is so important so that they can make informed decisions about whether they decide to have a family. They know the options. They know, the potential of whether your child will be a carrier, will have thalassaemia major. So, yeah, we really promote the awareness of the condition and of screening.
Thank you, amazing.
Similarly to what Gabriel said, the sickle gene is recessive, so you need to have both genes to have the condition. If you're a carrier and you have a child with another carrier, there's a 25% chance at every pregnancy. And with a lot of the awareness going on now about both sickle and thalassaemia, a lot of the young people are very aware and want to know what their genotype is before they get into relationships and things. So we promote, finding out your genotype so that you can make an informed choice. Not to tell you what to do, but at least education is key for that. So we have lots of questions coming to our helpline about that, about where can I get tested, blah, blah, blah.
Now, Amanda and then Kesewaa, I'd love to kind of build upon what Iyamide and Gabriel said there. And I guess, as medical professionals, why do you both think it's important to screen for both thalassemia and sickle cell?
Adding to what both Iyamide and Gabriel has said, is raising awareness. And they're both lifelong illnesses. It's inherited, and it will help not just the individual with the illness to know that they carry sickle cell or thalassemia, but for their family, for their friends, for the population, so that by raising this awareness, people are informed and they can have their screening done before they plan to settle down or have a family. And when they meet their life partners, they can also have that discussion. So putting out in the population, making sure people are aware and knowing about the condition and the risk that's involved. So we encourage them to test early. And we are very fortunate in England that we have a screening program which has been going on for many years, and it's well established.
So the screening program in England has been around for many years. I think WHO recommended that we had a screening program back in 1994. And we have been screening in London sort of informally from that time. It became more of a formal screening program around 2006. So it's a well-established screening pathway for sickle cell and thalassemia for pregnant women in England. And it's a pathway that is quality assured. It has shown in terms of evidence that it is beneficial, there is no harm, and it's part of the UKNSE screening recommendations that we do screen in pregnancy, and we also screen newborn babies.
Thanks for sharing that with me, Amanda. Now, Odi and Femi, you may have a bit of a different, I guess, perspective on this, or maybe similar but different experiences. So, you know, I'd love to know, Odi, did you know that you carried the thalassemia trait?
No. I was very young when I had my first child. I was 18, and the first time I'd ever heard of the word thalassemia was when I worked for my first antenatal, and the nurse actually mentioned it and asked me if I was a carrier. And I said I didn't know what it was, hadn't heard of it, no idea. And this was like, I think 76, early 76. And that was all I'd heard about it. And then I carried on with a healthy pregnancy. My daughter was born, everything was fine. 2.5 years later, I was pregnant again with my second child. But in between falling pregnant with Stephen and having Mariana, I was saying, I remember seeing, there was a drama, I think it was on BBC, about a Cypriot couple that were having a baby, and the woman they were both diagnosed with the thing, and it triggered off the memory of me being questioned about it. And in this drama, they had to make a decision whether they aborted the baby or... And I remember thinking, oh, that's what the nurse asked me about. And obviously I had to have a blood test every time I was going for my antenatal. So in my head, I'd assumed the fact that I hadn't heard anything back, oh, I'm not a carrier because they would have tested for it. Yeah. So, and that was what sort of second time I'd heard it. And then Stephen was born. I had a very bad pregnancy with him. He was a very, very sickly child, in and out of hospital constantly. By the time he was 2.5, he was just crying all the time, wouldn't sleep in the day, just wanted to be carried constantly. I was literally pulling my hair out. And then backwards and forwards to the GP, constantly going back. They actually wrote on my notes I was a neurotic mother, and sort of like saying, well, you know, I've seen the doctor 3 times this week, it's enough. My child's face was changing. His bone structure was getting very, very broad in his cheeks. Lips were purple, and he was skinny but had this really big stomach, and he wasn't eating and just was crying all the time, being carried. And eventually I went back to my local GP and I complained in the surgery. And at the time you had to see your own GP, you couldn't see a different one. And they were saying no. Anyway, I insisted. I said, I need to see another doctor. My child is very sick like that. So they let me see an older doctor that was there, and he asked me where where I came from, my genetics. And I said, well, Greek Cypriot. And he said, are you a thalassemia carrier? And I said, no. And he said, and I said, I don't really, know what it is. And he said, well, I'm looking at your child. He called there was a female doctor there, called her in. They both looked at Stephen and basically just said, look, we think he's got thalassemia. And all I remembered was back to that programme that he was nearly 3 and they died at 5, or if they got past that, they got to 17. So suddenly I've got this thing in my head. My child is now, if this is the case.
Yeah.
And it was a start of having to do my own research, really, because the GP said, go to Watford General, have some blood tests, then we'll see what happens. I went there straight away. They didn't do children's blood tests. It was the weekend. And my next door neighbour, I went in there crying, saying, what am I going to do, And again, I didn't know anything other than they died at that, very early age. So my neighbour said, look, I've got a friend who's got 2 sons that are haemophiliacs, and they're under this incredible professor at the Royal Free Hospital, and his name was Professor Hofbrand at the time. Maybe we can get in touch with the secretary. And so it was myself having to do all that, which went to see the Professor Hofbrand the week later. As soon as he looked at Stephen, he just said, I can tell that your he's got thalassemia major.
Yeah.
Anyway, we had to stay in for a week. Lots and lots of tests and treatment. They had to teach me how to inject him with the pump that Gabriel mentioned, which was to keep them alive from the after effects of the iron. And it's been a journey.
Yeah.
And luckily, he's now 47. He's struggled with lots of bone issues, lots of health issues, still struggling today. And this is my thing is now we're keeping them alive, but their quality of life and the things that they go through, there needs to be more for that now.
Well, thank you so much for sharing that.
But he got married last year. So.
Oh,
well, that's good.
That's amazing.
Yeah, and he married a lovely half Jamaican, part Chinese, Japanese.
Yeah.
But I think more needs to be done for their having a quality of life.
Yeah.
Their bones are really bad. They suffer with, heart issues, diabetes, lots and lots of different conditions.
Oh, thanks for sharing that with us. And I guess, I guess screening has changed a little bit since then, which is a positive thing.
It has, but I still think they miss a lot.
Yeah.
They do miss a lot. And when we talk to I talk to people all the time when I meet them, either about sickle cell or thalassemia, and they go, well, I don't quite know what that is. And they're from the nationalities that could possibly be carriers. And they seem to think that it won't affect them and even if one's a carrier, they said, oh, well, I'm just a carrier. But you might meet someone that, you need to be aware of that for your children or for future generations.
Definitely.
So I think that's just really important.
Yeah, no, I agree entirely. And now, for me, I know your experience is a little different because growing up, you knew you had sickle cell, and I just want to know, was that at the forefront of your mind when it came to dating, finding out whether the person you were with carried the trait or carried the same genotype as well?
Yeah, it's always been at the forefront of my mind when it comes to relationships. Because I struggle with the disease, and I wouldn't want my offspring to go through what I go through on a daily basis. So every time I think long term or any type of potentially being a child, my first question is your genotype. I have a son right now. He's a carrier. And the first thing we did when I met his mom was to get the test out of the way to make sure that she's okay. I always knew that there's a possibility that he'll be a carrier because I'm full-blown SS. But I know that what I do now is try to sensitize him to get him to be aware of what sickle cell is, what the trait is, so that when he's in that, when he's at the age and thinking of, families and kids, he would also do the same thing.
So with, his mother then, so when did you ask her to get a test then? That's what you're saying?
Yeah.
Yeah, and how easy was that to do?
It wasn't. I never think of it as something difficult. I always bring it out, I explain to them what the disease is. I explain to them the risks and the issues that we might encounter in future if she's a carrier and I'm full-blown sickle cell.
Amanda and Nkechi, can you speak to that as well in the sense of to actually get a test? Is it relatively straightforward?
Yes and no. I'll say yes and no. Currently, what we advise, a lot of the churches now are encouraging their parishioners to get a blood test before they get married. We encourage pre-concept screening, so not for the women or men to wait for the woman to be expecting a baby before you go to have a blood test. Ideally, GP surgeries is the first port of call. However, sickle cell and thalassemia centers dotted all over the country are the first port of call that patients feel it's more straightforward to get a phone call, book an appointment and get tested. For South East London Centre, where I work, we get inundated, people wanting to know, and a lot of them say they've been to their GPs, but they had difficulty accessing the program via their GP, and they will go to the centres. And we're quite happy for people to phone up their local sickle cell and thalassemia centres to get their blood test done there.
That's really, really interesting. I feel like I was just going to ask, I guess, what are the challenges when it comes to getting people to test for both sickle cell and thalassemia? So, you've said there that people will go to the GP and perhaps there's a bit of a wait, so they go to the centres and get answers that way. I'd love to know, are there any other challenges that people encounter?
For us, it's about getting the message earlier on. So, before they've met their partners, they've started a family, we really encourage people to get tested so they know their carrier status. And I think that's the challenge, just the education and the awareness, so that when people get to the stage where they've found a life partner and they decide, okay, we want to have a family, they already know their carrier status, they already know what their options might be. So that for us is the education side of it, and the awareness is really important.
Yes, and Iyamide and Amanda, is this something that you've encountered as well?
I mean, what I would say is if you know your genetic ancestry and that you are from a part of the world that may be at risk of sickle cell or thalassemia, the first port of call, if you're thinking about having a baby, and I've heard, how important that is, that you do see your GP. And that the GP should then be able to assess whether you are at risk and what test would need to be done. There are the sickle cell and thalassemia centres, which also may offer that service in terms of testing, understanding how important it is to have that knowledge, especially if you're planning a pregnancy. And sometimes, maybe in areas where there's low prevalence, where there isn't as much understanding and the numbers aren't great, in terms of it is a rare condition, sickle cell and thalassemia are rare conditions. There might be sometimes barriers in place to screening. And then what we would do is we usually contact the societies and ask them for help and support in order to direct in the right way. But there is that service there in terms of testing for those at risk. Where I would say there isn't a service is where your general population that are not at risk, going to the GP isn't really the right way of doing it. But for those that are at risk, then yes, definitely.
I'm glad you mentioned about if you're not at risk, because we get a lot of questions at the helpline of the Sickle Cell Society with people saying, because of the awareness that's been raised, preconception, people who haven't yet had children are quite aware of wanting to know what their genotype is. And we get a lot of complaints that some GPs do not agree to screen them. Even when, and as Amanda said, if you're at risk or if you have family who has sickle cell or thalassemia the GP might be more willing to screen you. But suppose you don't have family and you just want to get tested and there isn't an NHS centre near you. That's a bit of a dilemma, really.
Definitely, that's the big barrier.
Yeah,
there, isn't
that's a
it,
bit
really?
of a dilemma.
Yeah.
And some people think it costs, because we've even had that said to us that, you know, they think it costs. But I believe that if you're entitled to NHS services here, you don't have to pay for the test. But I don't know if any of you, because we get that question as well from people who may not be entitled to NHS but want to get tested.
I see.
So I don't know, Amanda, you know, where would they go? Or Linkages?
I think the first port of call is the GP.
Yeah.
I have a nephew who actually got married a couple of years ago, and he went to his GP twice to ask for the test, and the GP refused. And I did say to him because we have a screening once a year, we do it at the office. And people volunteer and come in and do the blood test for free. Yes, you do.
What I did first time around, I just took my partner on one of my appointments to my hematologist.
Oh, yeah. You're like, let's get right to the course.
Yeah.
Come on.
Yeah, so you went to your hematologist.
Yeah.
I used to go to the hematologist and I told her we would like her to screen and have a test done.
Yeah,
and she
yeah.
organised
It goes to show that even now, this is 2 years ago when my nephew wanted to have that test.
Yeah.
Twice he went to his GP and the GP said, no, we don't do that.
Yeah, and I
No,
feel
we don't
like
do
if
that.
someone says that to you, then
And
are you
he's
going to
got
go
a first
time?
cousin,
Yeah.
my son, who's got the full-blown.
Yeah.
I think one of the reasons, I mean, you know, because at the society we draw up a directive or what we do when people come to us, and why the GPs are refusing. I think one of the reasons is some of them are not aware of what the conditions are, for a start, you know, especially if you're in an area of low prevalence. Another thing is they probably think it should be the screening program that should test even preconception people, you see. So I think that and they probably think it costs, but I don't think it costs much for a screening test at all. So we have work to do there, I think.
It does cost less than £5 to have the blood test. However, just listening to what we're saying, ideally it will be in schools. If we can start at earlier on in primary school or secondary school to put the information in there. I tell you what, I started Sickle in 1998 and we were discussing how to improve screening then, how to improve awareness. And we're now 2025, we're still having challenges about that, although it's improving. But ideally, if school children are taught to know about their genotype, you carry sickle cell or you carry thalassaemia, and they prepare them all along. We don't wait for them to be planning a family in their 20s or meeting a life partner to be able to do that. However, the screening program, the newborn screening program, children who were born in the 2000s and late 1990s will have a record of their blood result. They will know. It's almost like a passport. I carry sickle cell gene. I carry thalassaemia. So in 10 years' time, those children are well equipped to have that discussion compared to their parents who were tested in the 80s or 70s. They didn't have that information.
Or not
so
even knowing.
we are improving with the screening program, the newborn screening program. We make that possible in the next few years.
Yeah, Oddy, you nodded along there.
I'm just, what you're saying I think is the right way, but you're saying so it'll be like a passport. So somewhere when they were born, this was written on a note. Now that child isn't going to be even aware of that.
It's for
Probably for the parents, and a lot of parents are not even, I don't know, sometimes everything just gets lost.
Yeah.
So it really does have to be, the parent has to be informed on that day.
Yeah.
Please pass this on to your children, talk about it. Even the parents have to be educated, because they'll 10 years, the baby will be 10 years old and they've forgotten that they've had this test or that they were a carrier. He's 17, he goes out, gets a girl pregnant, hasn't got a clue what's been going on. You know,
it's documented
so
in their
many.
records, and the GP have those records. So your childhood record information, not talking the red book, those newborn screening blood spot result is documented.
No, I understand what you're saying, but I'm saying, would that teenager be aware? And if he's had a lovely, healthy please God, growing up a healthy child and he's hadn't gone to the GP, doesn't, I ask people if they know what their blood group is. I've got adults that do not know what their blood groups are. My brothers, I say to them, do you know your blood group? No, I never thought about it really.
It's slightly different with blood group.
Would that teenager remember or know unless his mother's made him aware of it over his growing years?
Hopefully with the information being raised out there, the health promotion, they will ask questions before the plan.
I think it's great.
Before
and
17.
It's for going forward.
Yeah. It's good for the parents to support.
Yeah.
So when we give the result and we say to the parents now, your child carries sickle cell or thalassemia, which the test is done later on, that information should be gradually filtered through. The parents have a responsibility. We all have responsibilities. So as health professionals, the first part, we've documented this child carries sickle cell gene. The parent is informed when that result is given. And something that is long life experience shouldn't go off the radar.
Yeah, I agree.
Something that's important. It's almost like saying somebody has diabetes. It will go on, or you have epilepsy. Yeah. It's a medical history that is very, very significant. So the parents will have to share with that child. And as they grow up, they will know, okay, I carry sickle cell gene or I don't. And that will go with them throughout their childhood into their, but promoting, raising awareness. If we go into schools, we do teaching in schools, it will generate discussion.
Do that now?
Yes,
and what ages do you do that? What ages do you start?
Depending on we go into school, first of all, to educate the teachers, educate Senko, and some of the schools ask us to attend like school assemblies and talk about what sickle cell and thalassemia is. So those children, once they've got that information, they go home and they might say to mom and dad, oh, we learnt about red blood cell. There's been a lot of sickle cell information.
Do you do it in after secondary schools, not before that?
We do secondary school and primary school.
Primary.
Yeah.
Let me add also that, the outreach that the societies do. We do schools, colleges, and we had a film called The Family Legacy, which was about screening, the myths around it. But one of the points I want to raise as well is the stigma that's associated with the two conditions.
Yes.
Sometimes it stops parents from telling their children, because there's a lot of stigma and we need to get away from that so that we know that, look, this is a condition that came about because of nature's way of trying to prevent malaria, for sickle cell at least, genes mutate. So once you get, the stigma out, I think people will be more willing to talk about it. And we did, the societies did some consultation that included preconception individuals. And for the sickle cell ones, and I'm pretty sure for thalassemia, the sickle cell people wanted to know their genotype. Well, most of them did, but they thought it was very important to know it in your teens. So, the young, what do they call them, young Gen Z.
Remember what they call them?
Gen Z, Gen Z.
They're all over. They're up to it. They're up to it. And
I just think it's such an interesting discussion and something that, in terms of the screening programs, we've been thinking about, because it is a genetic result. And giving a child a genetic result when that child hasn't been, hasn't asked to have the test, and we've done it as a newborn, a baby, so the parents have been consented, and we've taken a test, and it's a genetic result. And we haven't actually told the parents that we're going to give the child the results. It does go on, you are right, it's on their GP record, and the child, when they're 16, can go back to their records and request them and see their results. For those that it was done, it started maybe 16 years ago, so it's probably just at the point where you could get your newborn blood spot results. But there's more work to be done around stigma. Some people do not want to know. It's an ethical issue around, do we give genetic results? And there's lots of changes around genetics, social change, and these things are new, and it's a new discussion that we're having.
Definitely.
And I think it's really good to have that discussion and work out where we're going to go with policy or strategy going forward.
Yeah, no, thanks for sharing that with us, Amanda. And I think, we were speaking about kind of the barriers before, and you've mentioned things like stigma, maybe a lack of awareness for some people as well. But I'd love to know, when it comes to perhaps, I don't know, like gender splits, have you found that when it comes to screening, people screening or testing as adults, is it more men coming forward or is it more women coming forward? Is it similar split?
Females. I think females go forward.
I think
more,
it's
don't
more
they?
female from our
Do you
perspective.
think that's an issue? Do you want more men to come forward?
Absolutely.
Yes,
Yeah.
please.
Vital.
Yeah.
I think especially with
you-
sickle cell, even also like
Well, you're probably, okay, for antenatal screening, they'll only call the man if the woman is a carrier of the gene.
Yeah.
But if you're talking about preconception as a whole, we did stuff that with this family legacy DVD I mentioned, we went into barbershops. I used to go into barbershops and educate the men, and you'll get so many questions about who said he went to the gym so he doesn't carry the gene. Who said, all this is, so they needed to be educated.
Yeah.
And I know the uptake amongst antenatal, when the mother-to-be has the gene,
Yes.
the uptake has now gone up, right? Before, when I started with the outreach and the screening program, I think it used to be in the 50s or whatever percent, but now it's probably up to 70 or something. So
it's
the men,
increasing.
the uptake of men coming when their partner has the gene.
Yeah.
Like say, fathers to be.
Yeah.
And some of them are afraid of the needle, They don't like taking blood.
Yeah.
That's one of the reasons. It's
Yeah.
not that they don't
Just
want.
on that,
Yeah.
when I was told Stephen was thalassaemia, and I obviously had to go because my husband wouldn't come to the hospital, couldn't cope with anything. And his first things to me were, it's got to be your family because there's nothing wrong with mine.
Yes.
And I said, no, we both have to be carriers. No, it's definitely not me.
Exactly.
it's an example of the stigma.
Yeah,
that's
that's
the
an example
Yeah.
of the stigma.
Just going on the blood test for the men, because, frontline, we invite them to come for blood tests. Apart from being needle phobic, some people don't like needle. Generally, no offense to the men in the room, men don't like blood tests.
Okay.
And trying to encourage them to come for the test, you've got to give them the reason why you're testing. Some people want, facts, data. It's not in my family. Nobody in my family has got sickle cell disease. They assume that the disease, you have to display some signs of it. But you could be we say you're a healthy carrier. You're healthy, you don't show any sign of the illness, but you carry the gene that you can pass on to your child.
Definitely.
So once you encourage them to say, this is why we're testing, and they want to know, are you testing just for that? Or is it for other illnesses? Is it for HIV? Is it for, I don't want my DNA being out in the open. I don't want anybody knowing my blood results. Once we cross over that hurdle, they will come in for the blood test. But you need to justify it.
I think the needle phobia is a real thing.
Yeah.
I don't like needles. I don't have a choice. I'll take
You don't have a
blood tests all
choice,
the time. But every time I go into the psychologically, when I'm not going to the hospital, my veins are all out.
Yes.
The day I have to go for blood tests,
They're
my
hidden.
veins will disappear.
Yeah.
Yeah. I have to go and tie my arm and squeeze it just to get the veins out.
It's a real problem.
I don't like needles.
Yeah.
And I have to do it all the time. So imagine somebody who do not have to
It's so
do a blood test. You have to
true.
convince them to go get a needle.
Yeah, it's so true.
Yeah.
I did have a needle phobia until I had to start learning to inject Stephen.
Yeah.
And we had to literally hold him down, wrap him up every night to get the needle in his stomach. He would fight and fight and fight. And it was like, every night it was, but I had to practice on an orange.
Oh, okay.
That was the way to do it, for about a week.
Spongy.
Yeah,
I think the first time they actually tried to take blood from Stephen, I fainted while I was holding him. And Professor and all I could woke up to him going, "Mummy, mummy, mummy," and I'm on the floor and that he's the one being sort of taking the blood. But yeah, it's a lot of people need. I don't. Does anyone like having blood taken? Has anyone not got a needle? No, I can't.
One thing I want to say as well is within the screening program, because they don't call the father to be if the mother to be is not a carrier.
Yeah.
And if the baby is born with the trait, the carrier, it means it came from the father.
Okay.
And some of the fathers
So they're
only
not aware
find
that-
out for the
Yeah,
first time
during that
Yeah.
moment.
when they do newborn screening,
Yeah,
you see,
yeah.
because they weren't called before for antenatal screening.
yeah.
And some of them don't like to hear that news.
So obviously we heard there lots of different experiences. We heard about oranges, practicing on oranges. We've heard about stigma as well, and how some men, are worried they don't want to necessarily come forward. But what are the important points in the antenatal screening programme?
So for women that are pregnant, some women that are carriers might not know that they're carriers. It's their first pregnancy, so they don't know whether they're at risk. So it's important that we test all pregnant women. So being a carrier status, as you've said earlier, there might be no symptoms, can be silent. And giving that news for the first time actually can be quite, have an impact on the family. It is a genetic result. Because it's a genetic result and it might require further testing, as in prenatal diagnosis, so that's something like an amniocentesis or CVS, chorionic villi sampling. These are quite invasive tests to see if the baby, the fetus, is a carrier or has the condition. So because they're quite invasive tests, we want that done as early as possible in pregnancy. So one of the key points about antenatal testing is to get screened as early as possible in pregnancy, so that women have time and families have time to think about that, whether they do want those further tests. It's a very personal decision. They need to get the information, they need to be fully informed, and need time to think about what they want to do. And that's because when you get the result, if the baby has a severe condition, one of the options would be a termination of pregnancy. But also in terms of the health of the woman and the health of the baby, it's to make sure that with early testing and early diagnosis, they can get into the right care pathway in terms of maternity. So the key point is if you are pregnant, then it's important to contact your GP, your midwife, get booked into the maternity service early so that you can have screening. If you know you're a carrier, fast tracking. There is a fast track pathway. Get hold of your maternity service and tell them that you're pregnant and you are a carrier, and you will be fast tracked into the service.
Is it important to do that every pregnancy, would you say?
Yes, and part of what I've heard today about the discussions about what it was like 10 years ago, what it was like 2 years ago, science changes, methodologies change. So even though you may have had a result, genotype is important, phenotype is important, understanding the variant. So because technology, methodologies move, it's important, best practice, to get tested in every pregnancy.
Now, what if there's screening inequalities? Do you come across that often? Do people feel like maybe they've tried to contact their medical professional, their GP, and they try to come forward and perhaps their concerns aren't taken seriously, would you say, about screening and testing?
I think as a health professional, understanding why it is important to be screened early in pregnancy. For some cultures, some religions, they do want the offer of prenatal diagnosis, which again could mean that you are then offered a termination of pregnancy, and they want to go down that pathway.
Yeah.
But because of culture, religion, and maybe terms such as ensoulment or quickening, at that point, those options are no longer viable for that woman, that family. So the inequality exists if you don't get into the pathway early enough, if you don't understand the pathway, and maybe if the health professional doesn't understand the timeliness of why you would want this early. You do want to have a prenatal diagnosis, but the barrier is the timing of it. If the health professional doesn't understand them, then there is a barrier and an inequality there. So I think you touched on this then, Ketchy, but communication is key here.
Yeah.
Getting the right information that sets out how important it is to screen early and to make sure that we are focused on those that are high risk. And those that are high risk may be, in terms of time, in terms of religion or culture, that they are needing to have that information early on in pregnancy, and we need to make sure we can do that.
Can I just add to what Amanda said? In March, the two societies did training sessions on the communication of screening results, and we had experts come on, we had patients, mothers come on, and people with children with sickle cell who had experience of the screening program. And those sessions were really, really good, because we had about 150, it was online, and both sessions had over 100 health professionals come on for both antenatal and newborn. And Amanda and Nkechi were on it as well. And I think that was really, really good, because it's them hearing firsthand what the service users want, so that they can provide a good service. And the screening program supports that, and we, the societies, help them to do that. So it's quite a good combination, really.
Yeah, so you've seen kind of the fruits of your labour there, you would say, and kind of the fact that this kind of, your efforts and initiatives are making a difference. Would you say up and down the country, there's screening programs on equal level playing fields, would you say? Or would you say that maybe, maybe in Birmingham or in Liverpool, maybe there's a bit of inequality, or is it?
No, I think in terms of England, there is a standardised approach in terms of screening and the screening pathway. What I would say is, because of social change and people migrating out of inner cities into more towns and rural areas, there is a change in prevalence maybe throughout England.
Prevalent areas do exist. But hopefully, London is one of the cities you mentioned, Liverpool and Birmingham, they are high prevalence. But I get what you were trying to say. In the middle of Devon, for example, you might have 1 or 2 or 3 women who are carriers of sickle or thalassaemia, compared to London, where the numbers are high. But then with migration, people are moving out due to housing issues. We've got patients moving to Scotland, Ireland, and even further afield. So the information should be the same on the website. The information that the parents are giving and the women are giving should be standardized. However, it's just the numbers, they might see less compared to London.
Also, let me add, when we did the consultation, people who were in areas that had NHS screening centres, mothers, they felt they had better support.
Oh, that's good. That's good.
And those centres aren't all over the country, so obviously.
That's true. We spoke there about testing. So is anyone eligible for the test? Does it matter where you're from?
Okay, so in England we call it 2 algorithms. So we have a high prevalence algorithm and low prevalence algorithm in terms of testing algorithms, which means that we use in low prevalence areas, so where the condition is really quite low, we would use a screening tool, a family origin questionnaire. And we would go through that family origin questionnaire, and where we find that you may be from a high risk population, we will then go on to do the blood test. In high prevalence areas, we do fill out the family origin questionnaire, but we would do the blood test straight away. Regardless of where you live, if you do want to have screening for sickle cell disease, you can request that, and it's in the policy that you could have the test. It doesn't matter where you live. What I will say with thalassaemia is that because there is a full blood count taken in pregnancy anyway, actually we would pick up thalassaemia majors. So we do pick up regardless of where you live.
Thalassaemia major, not the trait?
We would pick it up. We would pick it up. But so in terms of the algorithm, that's more to do with sickle cell rather than thalassaemia.
Really interesting, isn't it?
We need to get into that.
Yeah, it's really, really interesting.
We pick up all the carrier thalassaemia women in pregnancy.
Yeah, in pregnancy.
But the newborn screening doesn't pick up babies straight away
Okay.
with thalassemia,
Okay,
except
interesting.
thalassemia major.
Yeah. Do you think maybe is technology and science heading in the direction? Do you think one day it'll be able to pick up the trait of thalassemia? You know, if you're a thalassemia carrier.
I think so. Looking at with the money and things.
So the evidence around giving a carrier result, and it's probably what I said earlier about giving a genetic result, that actually in terms of physical health, if you're a carrier, you are usually healthy and well throughout life. So there is, again, this issue around giving a genetic result where actually it isn't, you know, the child hasn't asked for that. It isn't that they have the condition, the severity of the condition. It's a carrier result. We don't switch. It's not switched on for newborn screening for thalassemia carriers. For sickle cell carriers, it comes up. Just with the methodology that we use, we can see it, and when you can see it, we report on it. But the screening programme for newborn blood spot is there to pick up the severe condition of sickle cell disease. It isn't there to pick up sickle cell carriers. It's just that we do pick it up as a byproduct. If you pick anything up, you will report it.
Okay.
So we pick up thalassemia, although we're not looking for it, we do pick up thalassemia and we report it, and we have all the quality assurance measures around reporting that condition and making sure that referral and treatment are in place for that baby when we do pick it up.
So we've had some questions in from our listeners and from the audience. So I'd love for you to pick out a question if you feel comfortable, and then maybe we can have one of our health professionals answer it.
Okay. Who gets screened when patients' relatives get screened? We have a lot of refugees, migrants. When would be prudent to screen unknown patients?
Who gets screened? Okay. When patients get screened and we inform them of their result, and we encourage them to cascade the information to their relative, so that way the population you're reaching out. So if somebody's found to be a carrier of sickle cell or thalassemia during pregnancy, you say, tell your family and friends so that they can get tested. In terms of refugees, we did have a project in Southeast where some of the refugees, where they are in the homeless unit, do get tested as part of the package of screening when they come into the country. I don't know about other areas, but it's out there, and GPs should inform them. When will it be prudent to screen unknown patients?
It's a hard one.
Yeah.
It depends on known, but screening sometime during operation or in emergency, they need to know their hemoglobin status before, because red blood cell help carry oxygen around the body. So both sickle cell and thalassemia, you need your oxygen going around. So if they're going to operate on someone, for example, they need to know their hemoglobin status to know if they need more oxygen or not. I hope that's answered it.
Yeah. Gabriel, can I get you to ask the question as well?
Hope it's a good
Good
one.
mix, yeah.
There you go. Okay, if I want a second electrophoresis test for accuracy purposes at the hospital, can this be requested?
Does anyone want to answer that? And even explain what a first test does as well?
Definitely. I've had a situation where a woman was tested antenatally and she wasn't convinced because, of course, she did not fit the profile of those. She believed she wasn't from that ethnic group that needed that. And she asked for a second opinion. We did offer a second blood test. It's the patient, we put patient first at the center of everything we do. So if somebody feel uncomfortable with their result and they wanted a second opinion, we did offer that and we tested. But thankfully, it was still the same result.
Oh, okay. Yeah,
but they have every right if they feel uncomfortable. And because we cover 3 or 4 different hospitals, you can send the blood test to a different hospital just for them to feel. But that's in my area. I don't know about other areas.
So they can get someone else's opinion then. Oh, great. Would you like to answer a question? Thank you. Teamwork.
Equal framework.
Yeah, thank you.
What are the criteria for pre-implantation genetic testing?
Do you feel like we've answered that, or do you want to?
No, it is different.
Okay, yeah,
I mean,
yeah.
I'm not an expert in it, but I do know there is criteria that's set out by ICBs, so the Integrated
British
Care
Care
Boards do have a criteria in their boards that you can actually see if they're online. You can contact your ICBs for what the criteria is. What was the other bit of that question?
Just as what are the criteria for pre-implantation genetic testing?
Yeah, and it would be hard to actually answer that question without seeing the individual in front of me, because it would
Yeah.
depend on age, ethnicity,
Yeah. whether
it's the first baby.
Yeah,
So,
it does.
so that is sort of a one-to-one with your obstetrician, your fetal med team, your GP. But in terms of policy and criteria, the ICBs do set them out in each different area. So that's where I'd signpost you to, is your ICB.
Sometimes we get couple who are living with the condition, so they've got sickle cell disease or thalassemia, and they want to have a child without the illness.
Yes.
So they will go to Sickle Cell and Thalassemia Centre, be assessed by the counsellors, and then a formal referral will be made to the PGT centres, like one of them back in Guys. And some of the criteria is, obviously, they need to have their blood results, so are they carriers. So if the couple carry the gene, both of them, and we know there's a 1 in 4 chance of the baby being born with sickle cell disease, then they will refer them. So they want to have a child without the condition. And what Amanda explained about the egg being, to choose the one that is not affected. And it's almost like IVF process. So the couple, rather than waiting for the woman to be pregnant and then have prenatal diagnosis where they test the baby, they will do the testing before they get pregnant. And the criteria will include their age, their BMI, if they're smoking, non-smoking, if they've been in the relationship for over a year, and the costing and their GP. All that.
It's on an individual basis each time. It's not one rule fits all. It's literally the individuals each time.
There is a set criteria that's set out in each ICB, and there is a failure rate to it as well. It's not 100%. So that's why that is a really important discussion to have with your health professional.
So they do it before you're actually pregnant. So they will save some eggs as well for future pregnancy if it's successful. But it is a long process.
How long is this process?
You might need 2 or 3 rounds of it, and even then, it might not be successful. But
I actually have one of my nephews has just done that, and they're actually successful, and pregnancy's going really well. And because they both knew they were carriers before they got married, so they went through the whole.
Yeah, it's a long process.
I
mean, it's been around a long time.
Yeah, it's been very successful in many cases, but then obviously you get some.
So it used to be called pre-genetic diagnosis, but now it's called pre-genetic testing, PGT. So it's a good choice. It's an offer that is there. At least it's available for the couple, rather than go through, get pregnant naturally and find the baby's affected, and you still have to make that decision. Do you proceed with the pregnancy or stop the pregnancy? So this way you're having a different option.
It's not accessible everywhere, that's one. It's very expensive. It's not accessible everywhere. We get requests about that. And I know that one criteria, I don't know if that's changed, but you should have had a child already with sickle. I don't know if that's changed.
No, it doesn't, not anymore.
That does not anymore? No. Okay.
Because it's quite unfair. It's almost like you're being not punished, but penalised because you've got a child already, so you can't,
No, there were I think they were actually
You have to
saying,
have a child with a
before-
condition
before
to
you
be
can go
referred.
for the-
No, we
yeah,
don't
so
do
now
that
they-
anymore. Yeah. It could be their first pregnancy.
I think I would signpost to the ICB because you might have a slight difference in whichever policy depending on where you live.
These
But
are
I do-
integrated care boards, is it?
Yeah, but they are across England, and I know Guy's and St Thomas's do satellite clinics in, is it
they
Leeds, Sheffield, so they are available across the country. And I think I would start with the ICBs.
Well, thank you so much for joining us today. And episode 4. It's been really fun to speak about thalassemia because I think this is our first time actually discussing it on the Sickle Cell Society podcast. So thank you so much, guys.
Thanks for inviting us.
No
Appreciate it.
worries.
Thank you.
What an interesting and insightful chat. We heard about testing, screening and stigmas. Now, as a reminder, if you've got any questions, your GP is your first port of call. You've been listening to the Sickle Cell Society podcast, supported by NHS England, and today we collaborated with the UK Thalassaemia Society. I'm your host, Kesewaa Browne, and I'll see you next time.